Hello everyone, and again, as you can see, I've already written down what our topic of discussion will be, that is disorders associated with inflammation. Now, this is a topic that we are covering at the very end of our discussion of the entire process of inflammation, because this is a topic which will be incorporating a lot of the stuff that we have already studied from our previous discussions about the different steps of inflammation. Okay, so essentially, obviously, it's self-explanatory what we'll be talking about. We'll be talking about the conditions, the disorders, the diseases, the defects, whatever, which are associated with an abnormal inflammation or an abnormal inflammatory process. Okay, so that is why we need prior knowledge of the actual inflammation process, and that's why we are covering it after we have already covered the entire inflammation pathway. But there is a but to this. But as far as the disorders associated with inflammation, this topic is concerned, this is actually, you might say, it has two subheadings. Okay, it has two subheadings. What does that mean? It means that when you're talking about disorders which are associated with inflammation, it might mean either of these two things. Number one, it can mean that the inflammation is causing damage to the host, and the host benefit is kind of being outweighed by the host damage, because as you can probably remember, I had mentioned that inflammation is a double-edged sword. So there is always a very fine balance where inflammation kind of is damaging for the host, but it's also beneficial, it's required. That balance always needs to be kept on the favor of benefit. But sometimes what might happen is that inflammation might induce damage. That kind of becomes what we say to be inflammation. Okay, let's actually abbreviate this. So yeah, sorry sorry inflammation induced damage. This is a certain heading for all those problems, those diseases that inflammation is causing damage to the host, and that is actually kind of outweighing the beneficial effects that it has. This is one subheading under the disorders associated with inflammation, and the other subheading, which is our topic of discussion for this video, is defective inflammation. Defective inflammation due to defect in, let's use white for white blood cells, leukocyte functions. Okay, so this is the second category of, you might say, disorders which are associated with inflammation. All right, so the first heading, which is the inflammation induced damage, we cannot talk much about that here because it's probably the entire pathology is actually inflammation induced damage. What I mean by that? See, if we are to talk about this, we have a variety of conditions where there are disorders arising solely due to inflammation outweighing the beneficial, its beneficial effects. For example, asthma. For example, ARDS, acute respiratory distress syndrome. For example, glomerulonephritis. These are all very, very extensive topics within themselves, and we cannot talk about them individually. We can only exemplify because all of these are conditions which are associated with different organ systems. For example, asthma, acute respiratory distress syndrome, they are conditions of the lungs. Glomerulonephritis, kidneys. Then you might say rheumatoid arthritis, or let's use a different ink because I'll tell you why I'm using a different ink for rheumatoid arthritis. Rheumatoid arthritis, or for example, you might say atherosclerosis. Atherosclerosis. These are conditions, I'm actually inking them with the green because these are conditions which are associated with, you might say, chronic inflammation. And these white ones are more or less conditions which are, you might say, acute inflammation. What this means is these are diseases in which host response, the host response is actually a significant, you might say, mediator of tissue injury. So here the host itself, the host tissue itself is being damaged due to very high inflammation. So these are all inflammatory conditions. As we had talked about in our very first discussion, inflammation is a body process. It's a body response. It's a host tissue response, mainly by vascularized tissues. Why? Because it's kind of a defensive mechanism that our body has to undergo to rid itself of the offending agents, which can be anything from infection causing agents to foreign bodies. A lot of things can act as, you might say, initiators of inflammation, but inflammation is a required process. But as I had mentioned, inflammation is a very taxing process on the body itself as well, because inflammation causes some damage to the host tissue as well. If that outweighs the beneficial effect, then we get a lot of these conditions where the inflammation itself becomes the disease, the disorder source, you might say. If the inflammation is acute, then some examples of that is asthma, although asthma can be chronic as well, by the way. Okay, we'll talk about this later in, I think we have talked a little about asthma in pharmacology, right? But in pathology also we'll study about that later. Then acute respiratory distress syndrome, glomerulonephritis, there are other examples as well, don't worry. But chronic also there are examples, for example, rheumatoid arthritis, atherosclerosis. So these are all conditions which are associated with, as you can see, inflammation induced damage disorders. Now, having talked about the, you might say, secondary topic for this video, let's go on with the actual topic of discussion. The actual topic of discussion that we are going to pursue in this video is the defective inflammation due to defect in leukocyte functions. This is the topic at hand which is very important as far as inflammation is concerned, because we have just very freshly learnt about inflammation and the process itself. So this will be a more, you might say, local topic to cover. This is a more general topic to cover because the entire pathology will be about, or rather the entire systemic pathology will be about the different organ systems and their diseases and their disorders, and within those organ systems we'll talk about the individual problems. But this one over here, this is the topic that we have to learn in this video. So again, this won't be a very long topic, don't worry. So let's start with it. Let's get on with the line and let's put on the heading. The heading is, let's go with red, defect in leukocyte function. right? So now what we are going to do is we are going to scroll up and see all the processes more or less, and from there we will actually talk about the various disorders. Okay, so let's go on to over when we were talking about, suppose, yes, over here. Remember this? These were intravascular cellular changes. We have talked about this, the intravascular cellular changes, wherein there was firstly margination, then there was rolling, then there was adhesion, and then there was the transmigration or diapedesis, right? So when we had talked about rolling, adhesion, we had talked about a couple of very important molecules. See, they are written over here. What are they? They were, for example, silyl Lewis X or selectin, and also we had integrins. So what exactly were these molecules doing? If you remember, we had said that the interaction between these molecules expressed on the leukocytes and their complementary molecules or receptors which are expressed on the activated endothelial cells. Their interaction, initially it causes a loose adhesion, which is rolling, and then complete stoppage of firm adhesion, which is due to interaction between the integrin molecules which are expressed on the activated leukocytes and the adhesion molecules which are actually expressed on the activated endothelial cells. So now with that knowledge kind of at the back of your mind, let's talk about what would happen if there was a deficiency in those molecules. So suppose you don't have enough integrin, or you don't have enough silyl Lewis X. What would that lead to? Obviously that would lead to problems, because that is not supposed to happen in a normal inflammatory response. You are supposed to have adequate amounts of all those molecules, but suppose due to some genetic defect those molecules aren't expressed enough, aren't produced enough for a person to have a normal inflammatory response. What would happen then? Then the person will actually, this is the first topic at hand as far as defect in leukocyte functions is concerned, then the person would have what we say to be a couple of disorders, or the person himself or herself wouldn't have those couple of disorders, he or she would have only one of those disorders, but collectively these disorders, they are something which are known as leukocyte adhesion disorders. Obviously is extremely self-explanatory, couldn't have been more obvious. LADS, leukocyte adhesion disorders, because here there is a disorder which is associated with the adhesion of leukocyte. Can be the loose adhesion which is rolling, or can be the firm adhesion which is actual adhesion. Disorders in that, defect in that. So what would, from your common sense, what would happen in that case? What will be the clinical picture of a patient with leukocyte adhesion disorder? Very easy. You have a problem with leukocytes. So what will be the clinical picture? Yes, obviously, very good. The most obvious clinical manifestation is there will be increased, very highly increased incidence of infections. It couldn't have been more obvious than this. Obviously, you have a problem with leukocytes, so a very high incidence of infections. The person would get infected very quickly, would have a harder time to fight off that infection as well. Another problem, another clinical manifestation is neutrophilia. Neutrophilia means that there is very high numbers of neutrophils in the blood. Now, why is this the case? This is also pretty, I would say, self-explanatory, but it's not that obvious as the first point. The reason is, since you have a problem with the adhesion, and since this is a problem which would essentially mean that in this case the neutrophils would have a problem to transmigrate to the offending agents which are present outside the blood vessel. Because remember what adhesion was all about? It was a ploy, it was a tactic which was employed by our body to kind of push the leukocytes, to push the neutrophils out of the blood vessel so that they can migrate to the offending agent source which is present out of the blood vessel. But now you cannot do that. So even when there is increased infections, even when the body is kind of responding to that by increasing the production of leukocytes, by increasing the production of neutrophils, there isn't much change as far as the body's infection response is concerned, because those increased number of neutrophils are not able to reach the source of infection. They are trapped within the blood, which would mean neutrophilia. High numbers of neutrophils in the blood. Okay? And another very important and again very obvious clinical manifestation, which is no pus formation. Pus is actually a very important, and this is something that I don't think I have talked about in the actual inflammation topic videos. Pus is actually kind of a product. It is kind of a, you might say, end product, a byproduct which is formed due to the entire inflammation process taking place. So due to inflammation, as I had mentioned, inflammation is a very taxing process, but the main objective of inflammation is to kill all those offending agents, as bacteria, viruses, parasites, whatever, foreign bodies, to rid them off. And in this process, there is a lot of damage and destruction to the body cells as well, especially the cells which go on to fight these battles, which are the leukocytes. So all these damaged cells, the damaged, you might say, cells and cell debris and dead microbes, together they form a kind of a fluid like exudate, you might say. It's not an exudate actually, it's kind of a fluid like accumulation at the site of inflammation, after which, or rather the formation of which means that the inflammation has taken place. The battles have been fought, these are the dead bodies. Here lie the dead bodies of enemies as well as the soldiers of our body. So that kind of fluid, or that kind of you might say end product, that is actually the pus. Okay, and that is why pus is often white, because yes, white blood cells, they have fought the battles, right? So there is a very high concentration of white blood cells in that. That is why pus is often white. So pus, from this kind of small discussion on pus, what I want you to remember is pus is actually the product of inflammation. Here there is defective inflammation, no inflammation actually taking place. Inflammation cannot progress, cannot advance, so there is no pus formation. Okay? So these are more or less the general manifestations of leukocyte adhesion disorders. But there is a but to this. Depending on what deficiency you have, do you have a defect in integrins or do you have a defect in the selectins, the sialyl Lewis X molecules? Depending on that, leukocyte adhesion disorders are of two types. Okay? pure information. This is completely information. This is not a very obvious thing, or this is not common sense or stuff like that. This is completely information. So one of them is called obviously LAD1 and the other is called LAD2. Okay, LAD1, LAD2. LAD1, 1 in Roman looks like I. So we can say that LAD1 is due to integrin family of molecules defect. Let's actually draw a line here. Okay. So integrin defect, I and kind of I, Roman 1. Okay. Now obviously we know that integrins, there are varieties of integrin, because integrin is not just one molecule, it is actually a family of molecules. And in the actual information process, I think CD18 was a very important integrin. LFA is a very important integrin. So defects in them, defects in their formation, that would actually lead to leukocyte adhesion disorder. What type? Type 1. Okay. Whereas this one, type 2, 2 means second, S, second, S for sialyl Lewis X defect. Okay. So the hints for remembering what causes these defects is in the name itself. LAD1 integrin defect, LAD2 or LAD second S sialyl Lewis X defect. Okay. So now a little more detail about, just a little, not too much obviously. First thing that you need to remember is LAD1 is a little more severe than LAD2. Okay. Little more severe, not too much. It is a little more severe. Less. Third point, and this is the most important point. Okay, the most important point, that is, how exactly are you going to differentiate sitting in a clinic as a doctor, as a physician? How are you going to differentiate between a patient having LAD1 and a patient having LAD2? So the clinical manifestations for LAD1 and LAD2 are a little different. Obviously they will have the shared points, shared clinical manifestations of these 3 points, but they themselves will have a few very special markers, very special identifying points. For LAD1 there is only one very specific marker by which you can recognize it immediately. LAD1 is often, since these are genetic defects, so often the targeted patients here, population rather here, are infants. Okay, so in the pediatric group you might say. In LAD1, often it has been seen, the mother describes that during childbirth, if the child has LAD1, it has been seen that there is, let me use another ink here, delayed separation of umbilical cord. Very, very important. If the child has LAD1, it has been seen that during the childbirth there is a delayed separation of umbilical cord, and the reason for that is that separation of umbilical cord would actually mean that there is a local ischemia. Okay, this local ischemia would mean that there is a local inflammatory process going on, local inflammation. This would mean again that all those steps would likely be occurring that we have talked about as far as the inflammation is concerned, and so adhesion would also be occurring, but now there is a defect in integrins. So that would mean due to integrin defect there will be less number of WBCs reaching to that site of inflammation, which in this case is also the site for the local ischemia, where the separation is actually happening. Less number of WBCs means the inflammation process would take longer, the ischemia that would actually take longer, and the separation will take longer. Okay, so this is kind of a rough, I think there is more to this. I'll have to kind of see to this a little bit myself, a little more to this, but this is more or less what you actually need to understand here. Okay, that there is a delayed separation of umbilical cord. Now, as far as leukocyte adhesion disorder type 2 is concerned, that is due to Siley-Lewis X defect. Again, what are the distinguishing features for this as far as the clinical picture is concerned? For understanding what the distinguishing features for this is, you need to understand how exactly Siley-Lewis X is defective or deficient rather in the first place. You see, let me give these in brackets. There is a certain enzyme called fructosyl transferase. Fructosyl, okay, let's use another ink because green is something that I'm using for the clinical manifestation only. So let's use, yeah, blue, why not? Fructosyl transferase. So fructosyl transferase, this is the enzyme which is kind of responsible for Siley-Lewis X formation. Now, if there is a deficiency in this enzyme, obviously that would translate to Siley-Lewis X molecules being defective or deficient rather. Now, this enzyme fructosyl transferase, this has some other functions as well. That would mean if this is deficient, Siley-Lewis X is deficient, but if this is deficient, the other functions are deficient as well, and those other functions will translate to clinical manifestations in Siley-Lewis X defect, which is LAD2. So, what are the other functions of fructosyl transferase? One function is actually it's not a very specific function, but it is actually something which is formation of a lot of very important chemical mediators in our body, which would mean that if fructosyl transferase is deficient, the clinical manifestation here is that the patient would have short stature. Okay. The other function of fructosyl transferase, and this is very important, is that it is actually needed the formation of H antigen on RBCs, erythrocytes. What does this mean? See, this short stature, by the way, this is a clinical picture for differentiating between LAD1 and LAD2. But what does H antigen mean? Very quickly, suppose this is an erythrocyte. Okay, erythrocytes, they have an antigen on them. This antigen is H antigen. Okay, H antigen has a few side chains, may or may not have a few side chains on its side. Okay, there can be two types of side chains on H antigen present on the RBC membrane. If the side chain is, suppose, something called N-acetyl galactosamine, then this entire antigen, H antigen plus the N-acetyl galactosamine side chain, this is called A antigen. A antigen. Okay. Whereas if H antigen does not have N-acetyl galactosamine but rather has galactose side chain, then it is called B antigen. So A antigen means A blood group, B antigen means B blood group. If both of them are present, AB, like in this case, and if none are present, none, that would mean O blood group. However, for all of that to happen, H antigen itself needs to be present, because we are talking about side chains on the H antigen. In all of them, even in O blood group, H antigen is present. But if H antigen, for the formation of H antigen, for its functions, fructosyl transferase is needed. But if H antigen itself is not present, if that is defective, if there is deficiency of H antigen, as occurs in fructosyl transferase deficiency, then we get another blood group which is extremely rare, very rare. That very rare blood group is another clinical manifestation of leukocyte adhesion disorder type 2, and that is Bombay blood group. Bombay blood group. Okay, very, very important. So Bombay blood group and short stature, these are more or less the manifestations for leukocyte adhesion disorder subtype 2. So this is more or less the clinical picture for these two defects. Now, having talked about the disorders which are associated with leukocyte adhesion, let's now move on in the inflammation process. So in the inflammation process, the next steps, what were they? Transmigration, right? So in transmigration, let's first take it out. Yeah, transmigration. So transmigration, diapedesis, obviously the WBCs, they got out, and then started the cellular changes, or rather the extravascular cellular changes of the inflammation process. In that, we saw that there was, okay, let's take it out, I cannot find it, yeah, phagocytosis. But before that, there was something called chemotaxis. Chemotaxis, yeah, here. So these are the extravascular cellular changes, and in that we have chemotaxis. Now chemotaxis, as far as that is concerned, and then the actual phagocytosis, as far as even that is concerned, I had already talked about defective chemotaxis. Yeah, here. If there is increased chemotaxis, then obviously we give steroids, and because there is a high number of WBCs which reach that site, already talked about this, so we can move on. Phagocytosis, yes. So in phagocytosis, I had talked about something called opsonins. Opsonin and opsonization, right? In that, C3, actually C3b, this is an example of opsonin. IgG, yeah, IgG to be more specific, the FC part of IgG. This is an example, and lectins. These are again another example. So let's suppose we talk about IgG here. Okay, let's talk about IgG. So let's go back to that. Yeah. Okay. So this was actually the first one. Yeah. So now let's move on to the second one. So the second disease or disorder, whatever it's actually a disease, that is actually something which is associated with defective opsonization due to defective Ig or immunoglobulin production, or decreased immunoglobulin production. The name of that disease is Brutons disease. Okay, Brutons disease. So for understanding Brutons disease, we need to understand a little bit about how typically an immunoglobulin molecule is formed. It's pretty simple immunology knowledge that suppose this is an immunoglobulin that is actually coming from what? Plasma cells. Plasma cells are actually a little more activated form of already activated B cells, which by the way are activated from precursor B cell. So this is more or less the pathway. Now from precursor B cell to activated B cell, to activate the B cells, we need an enzyme. That enzyme is B cell tyrosine kinase. Okay, so B cell tyrosine kinase. Okay, defect or deficiency in this enzyme obviously would mean that there is defect or disease, or rather problems in immunoglobulin formation. This would actually mean that immunoglobulin their concentration would go down, which can be called hypogamma globulinemia, that is decreased immunoglobulin concentration in the blood, or if completely absent, it is called A-gamma globulinemia. A-gamma globulinemia. So Brutons disease is about this, which would mean that Brutons disease is actually, obviously this would have a host of other problems as well. We know immunoglobulins are extremely important for the immunologic response of our body as well. But this would also mean that there is a very small amount of immunoglobulin G, the Fc component of which is a very strong, if not the most important, opsonin. So if that is less in number, then obviously that would mean defective opsonization in whole, which would obviously then mean that all those processes from that step onwards will be hampered. So this is another disease which is associated with defect in leukocyte function and is associated with inflammation. Okay. Now this is comparatively a lesser important Brutons disease, but the next one, that is absolutely brutal, not Bruton, brutal, for remembering, for understanding. Okay, so let's go back. We had covered until opsonization. Brutons disease was about opsonization. So now let's move on from that. Are you seeing a pattern here? We're actually going on through most of the inflammation process and seeing where exactly a defect or where exactly a problem, where exactly a deficiency would cause a disease overall, which is noteworthy. Obviously, there are a lot of micro problems within these steps which are possible as well, but noteworthy steps or noteworthy diseases, noteworthy disorders that we are mentioning here. Now, we have already talked about opsonization problems leading to Brutons disease. Then there was the step of actual engulfment, right? And after that, phagosome formation, I had said that there is this protein, list protein, which was very much required for the phagolysosome formation. Now finally it is time to talk a little bit about this protein and see what problems the deficiency of this can actually cause. So this list protein, lysosomal transporter protein, this is actually required for transporting the phagosome rather towards the lysosome within the obviously white blood cell and their fusion causing phagolysosome formation. Then after the phagolysosome formation, the array of steps they can actually proceed and subsequently inflammation can take place. But if there is a defect in this list protein, there is a very characteristic and very famous disease, or rather syndrome because obviously it is genetic, and that is something that we call Chediak Higashi Syndrome. Okay, so Chediak Higashi Syndrome, this is, you've probably heard of this from biochemistry. In biochemistry also, under molecular targeting systems we had, I mean not in this channel, but it's actually something that is talked about in biochemistry as well, Chediak Higashi Syndrome, in the first chapter of biochemistry, that is cells. So Chediak Higashi Syndrome, that is actually a molecular targeting mechanism defect. Here what's happening is, as I have already mentioned, there is a defect. Defect in what? Defect in the, yes, the list protein, lysosomal transporter protein, which would mean, now obviously you can join the ends here and see what this means, what the implications of this would be. This would mean that there would be obviously defective inflammation and defective inflammatory response, defective immunological response as well, because as I have already said, and this is for the umpteenth time I am saying this, that inflammation is a defense mechanism. Our body is trying to rid itself of all those different problems. But that's not all. You see, list protein has been found to be very important not only for the inflammation process, it is also very much needed in some other cells as well. For example, it is very much needed in melanocytes. It is, let's first draw these. Yeah, very much needed in platelets. It is very much needed for our neural tissue, and obviously it is very much needed for our neutrophils as well. That is obvious. That's what the entire discussion was about. So now if there is a defect in list protein, all of these will be affected. Right? All of these will be affected. So what will be the clinical picture in Chediak Higashi syndrome? Defects in these individual components. So in, you might say, Chediak Higashi, what will be the clinical picture? The clinical manifestations. Number one, defect in melanocytes. So obviously, couldn't have been more obvious. Let's go with red. Albinism. You are having problems in melanocytes, so albinism. That is complete loss of pigmentation from skin. So albinism obviously means complete loss of pigmentation from skin as well as from hair. So albinism would obviously also mean that the person would have golden hair, okay, and completely white skin, like depigmented skin, okay. Then obviously let's move on. What is the next cell which has it? Platelets. So defect in platelet function would mean that there is increased chances of hemorrhage, increased hemorrhages because of platelet functions. The third one, what is the third one? Neural tissue. So obviously neurological manifestations. Neurological manifestations. And last but obviously not the least, neutrophil problems. So problems in the defense mechanisms in our body. So very high chances of infections. So these are more or less the external clinical manifestations that are seen in Chediak Higashi syndrome. But Chediak Higashi syndrome, there is actually something that you need to understand as far as the cytological study is concerned as well. So these 4 points that I have just mentioned, they are the external clinical manifestations, right? But suppose you order a blood test for a patient suffering from Chediak Higashi syndrome, what would you see in the peripheral smear? That is also a little characteristic as far as the findings are concerned. So in the blood peripheral smear, findings, what is found is that within the WBCs, the cytoplasm of the WBCs, suppose I don't have it, or maybe I do, let's go with blue. Suppose these are the granules, or these are the bilobed or trilobed nucleus, whatever, okay. And within the cytoplasm, it has been seen that there have been a lot of giant granules that are found, okay. A lot of, let's go with green, giant granules, okay, that are found in the WBCs of patients suffering from Chediak Higashi syndrome. So these giant granules, what are they? Yes, they are the phagolysosomes, or not the phagolysosome. Is it the phagolysosome? No, it cannot be the phagolysosome because there is failure of fusion in Chediak Higashi syndrome. So it cannot be the phagolysosome itself, but the phagosomes. So these are the persistent, you might say, phagosomes, which obviously could not be dealt with, the contents of which could not be digested due to the defective molecular targeting system, leading to phagolysosome absence or defect in phagolysosome formation due to defect in list protein. Okay, so these giant granules are the persistent phagosomes which remain in the cytoplasm because engulfment has occurred, but subsequent steps cannot take place. So this is all about Chediak Higashi syndrome. So combining these clinical findings and the peripheral smear cytology finding, you can easily diagnose a patient to be having Chediak Higashi syndrome. Okay, okay. Now let's again, what we do, we move on. So up until now we have talked until the phagocytosis process. In the phagocytosis process we have talked until the phagolysosome formation. Now if we move on to the actual killing process over here. Phagolysosome has now been formed. What were the next steps? The next steps were the actual killing, which could be oxygen dependent or independent. In oxygen dependent killing, which is the more important of the two killing mechanisms, we had talked about a few very important enzymes, you might say, which is, for example, NADPH oxidase, myeloperoxidase. These are enzymes, these are very important chemicals or proteins, the defect or deficiency in which would completely hamper the actual killing, and that is exactly what happens in a few disorders which we'll be talking about now. So this is the third one, I think. Yeah, so let's go on to the fourth one. The fourth problem that actually kind of can occur due to a defect in the NADPH oxidase enzyme, which was needed for the formation of all those reactive oxygen species molecules required for killing of the microbes or microbacteria. The defect in that enzyme leads to a problem, a disease, which is something that I had kind of talked about a little in the last discussion: chronic granulomatous disease. Now try to understand here, first of all, what this disease is and how exactly NADPH oxidase defect is leading to this disease and all the stuff about that. Remember, when I had talked about NADPH oxidase, I had said that this enzyme, NADPH oxidase, which, by the way, I don't think I had mentioned this, I had forgotten to mention it, I'm sorry. This is also known as the respiratory burst enzyme or respiratory burst oxidase. Okay, it is also known as respiratory burst oxidase and also called phagocytic oxidase. Phagocytic oxidase. Respiratory burst oxidase, phagocytic oxidase, these are pretty self-explanatory why these names have been given, right? We had talked about respiratory burst, the process, and phagocytic oxidase because obviously this is something crucial for phagocytosis, this enzyme. So the names are justified. Anyways, so this enzyme has two components, I had said. One is the membrane component and the other is the cytosolic component. And it's very crucial that these two components are there in the first place and not just only one component, because NADPH oxidase is a very highly important enzyme for the formation of very highly damaging, you might say, products, which can be very damaging for the cell itself. So it is absolutely crucial that this enzyme is only activated at times of needs and not just randomly, anytime, anywhere. So it has been seen that the membrane component and the cytosolic component, membrane of what? Membrane of actually the lysosome, which becomes activated after phagolysosome formation. So only after the phagolysosome formation has taken place can the cytosolic component merge with the membrane component. And the membrane component, since that is actually expressed only on the membrane of the phagolysosome, so that kind of ensures that only when phagolysosome is formed, NADPH oxidase is active. Okay, that's a relief. Okay, now, but that's not our point of discussion. Our point of discussion here is that the inheritance for these two components are different, as I had again talked about previously. The membrane component is actually X-linked and cytosolic component is autosomal. Subsequently, it has been found that chronic granulomatous disease can take place due to defect in either of these two. If the membrane component is deficient, then NADPH oxidase obviously would be defective, and the disease which we'll have is chronic granulomatous disease, which will be X-linked recessive. X-linked recessive disorder. Chediak Higashi, by the way, I think it was autosomal recessive, if I remember correctly. You probably would have to look that up. Anyways, cytosolic component, that is autosomal recessive. If that is defective, if that is deficient, chronic granulomatous disease will be autosomal recessive in, you might say, the disorder will be autosomal recessive, the disease will be autosomal recessive. Now, let's talk a little about, first of all, why the name is, or rather first of all what the clinical manifestations are, and from that only we will talk about how the disease is named so, why the disease is named so, and what exactly is happening. So, as far as the clinical manifestations are concerned for this disease, obviously, again, like any other leukocyte function disorder disease, this would lead to increased incidence of infections. No arguments there. But the second point is the more important point. Again, this is related to something that I had talked about earlier when we actually had talked about respiratory burst, that NADPH in N also is the starting letter for neutrophil, N. So, NADPH oxidase is absolutely crucial for neutrophils, whereas as I had talked about earlier, nitric oxide induced damage, the nitric oxide derived free radicals, they are very much important for macrophages and especially against mycobacterium, whereas NADPH oxidase is more important for neutrophils. So, if there is a problem in NADPH oxidase, which that would absolutely mean that there is a decreased efficiency of, or decreased effects of, neutrophils. This would obviously mean that our body would likely make up for this neutrophil decreased efficiency. How it would make up for that? It would try to make up for it by other phagocytic molecules. So, what are the more, or rather what are the comparable phagocytic molecules comparable to neutrophils? Yes, macrophages. So, to make up for neutrophil problems or deficiency, there is an increased number of macrophage formation, an increased attack by macrophages all over the inflammation sites. Macrophages are actually, we will see to this later when we talk about the hypersensitivity reactions in immunology. Macrophages are actually really related to something called granuloma formation. Granuloma formation. This is actually an example of type 4 hypersensitivity. Anyways, we will talk about this later. So, what has been seen is macrophage increase means there will be increased granuloma formation, and this is why the name of this disease is chronic granulomatous disease. So, there will be a lot of granuloma formation all throughout the organs and tissues to kill the microbes because of increased macrophage concentrations. Done? So, that is why this is chronic granulomatous disease. Okay. Now, there is actually a lot to talk about in chronic granulomatous disease, but we won't be going into the details of those. For example, there is a lot to talk about as far as the diagnostic tests for chronic granulomatous disease is concerned. This actually has been asked in previous, I think, PG entrance examinations. The diagnostic tests for granulomatous diseases. So, there is NBT test, and there is a dihydrorhodamine test, then cytochrome reduction assay test. So, all of these, they are actually there, and there is another point that I have actually forgotten to mention here. It has been found that in chronic granulomatous disease, in chronic granulomatous disease, I said that there is increased infection chances. To be a more specific over here, chronic granulomatous disease increased chance of infections by whom? By catalase positive organisms. So catalase positive organisms are more frequently infecting people with chronic granulomatous disease. C. Okay, this is another small point to be remembered. Now, chronic granulomatous disease, how will you treat this? Obviously, the treatment for this is like many of the genetic leukocyte defect problems. The treatment will be bone marrow transplantation. So, a little bit about the treatment. It will be bone marrow transplantation. Okay. So, bone marrow transplants. But obviously that's the more drastic treatment. To be a little more, you might say, light-headed treatment will be to start off the antibiotics and the antifungals or all of those organisms which can infect you, because you have increased chances of infection. So that is another mode of treatment, but that's actually not a mode of treatment. That's more like you're trying to delay the infections, because you're trying to treat the more immediate concerns here. That is antibiotics, and not just against bacteria, antifungals, antiviruses, all those, broad spectrum. So that, because obviously it's self-explanatory why it's broad spectrum, a host of microbes can actually infect you. Now you have decreased immunity. So broad spectrum antibiotics, antifungals, etc. And another very important treatment is by interferon gamma. Interferon gamma. Interferon gamma treatment is actually very crucial, also very helpful, because we need more macrophages, and interferon gamma can actually activate more macrophages. So this actually activates more macrophages, and we need those increased macrophages to make up for decreased neutrophils, right? So this is more or less about the chronic granulomatous disease, yeah, over here. And then again, we can also have problems related to myeloperoxidase. Not much to talk about this. So myeloperoxidase deficiency can be another problem, and there isn't much clinically unique features to this deficiency or disease. You'll just have a lot of problems. But something to note here is that when myeloperoxidase is deficient, first thing that you need to understand here is that myeloperoxidase is the most important. Myeloperoxidase, actually this is the most important enzyme for killing the microbes. So the myeloperoxidase enzyme that leads to the formation of hypochlorous radical with the help of a halide ion, obviously. So this is the most potent antimicrobial or most potent way of killing. Okay, this is an information that you can remember. But although you would expect that due to myeloperoxidase deficiency the effects should be severe, but it has been found that due to the incidence of other free radicals which do not use myeloperoxidase to be formed, the effects are not that severe, they are rather mild in myeloperoxidase deficiency. Right? For example, hydroxyl radical will still be there, then the peroxynitrile radicals will still be there, all of those will still be there. So they will kind of make up for myeloperoxidase deficiency. Okay. So this is more or less all about the genetic disorders in leukocyte function. As far as the acquired leukocyte function disorders are concerned, now these are something which is kind of beyond the scope of discussion as far as only inflammation is concerned, because acquired leukocyte disorders are more related to neoplasia and leukemia. Okay, so those are things which we'll study in subsequent discussions when we'll talk about leukemia or other blood cancers. So I think this more or less covers everything. At least the important things are covered here. So yeah, thank you very much for sticking about, and I'll see you later. Thank you.